Good afternoon and morning to those of you who are in the Western Coast. This is Dr. Adrienne Mims. I'd like to formally welcome you to the Physician Leadership Network Clinical Discussion Series that we've begun here in 2013. Today's topic is called Palliative Care and End-of-Life Care, and this is sponsored by our trade association, AHQA. Thank you, everyone who is joining us either on the webinar or by phone. All lines have been muted, and so I would ask you to use the chat function if you would like to ask questions during the presentation. We may hold the questions to the end. But I did want to give a little background as to why we're holding these conference calls. We, as the physicians within AHQA, which is the trade association for the Quality Improvement Organization Network, felt that it would be of value to have a vehicle to discuss topics that are relevant in our current work, but we think will be even more relevant in our work going forward. To that aim, we have set up these webinars, of which this is 6 in a series that we have had so far. Slide. And as we go forward, I did want to mention that, can you go to the next slide? I did want to mention that we have taken a specific effort of trying to get a variety of people on these calls. And to that end, we have asked that you complete a poll that's going to come up on the bottom right-hand side. And in this poll, we want to make sure that we're getting a variety of people on the line. So you see 2 questions there. We want to know what your role is in terms of attending this call. Are you a physician, a nurse, part of outreach, technical support? Are you with CMS? Because we felt that these topics would reach a broad audience. And second, how much do you already know or are involved with end-of-life care and palliative care before the start of this? So we wanted to get this type of feedback from you before the start of the conference. So the poll will close, and I'd like for you to go to the next slide, Dee. Today we have as our facilitator for this presentation Dr. Jane Peterson, and she's the medical director at Stratus Health, one of the prominent QIOs across the nation. She is very active in palliative care, board certified in internal medicine and geriatrics. And in her role, she not only does the quality part from the QIO, but she is also very active in clinical practice. Jane?
Thanks, Adrienne. Today, I think this is going to be a really exciting presentation. As we look at the agenda, we've got 3 presenters. The first presenter is going to be talking to us about Respecting Choices, which is an approach to advanced care planning aimed at achieving the triple aim. And then talking about the PULSE form, at how you do that at a statewide level, implementing it across the state of Georgia. And then we're going to wrap up with a discussion about palliative care in the rural communities, in rural settings. So trying to give a flavor kind of end-of-life palliative care, certainly not covering the whole breadth of the topic, but hopefully will give us some good things to talk about because we want to leave some time at the end for Q&A. Can you go to the next slide, Dee? The next slide is just the objectives for today, and really hopefully we're hoping that everyone is going to be able to walk away with being able to describe differences between palliative care and end-of-life care, getting a better understanding of the PULSE and how to, what are some of the barriers to implementation, and then also some of the techniques and ideas that you may want to use as you try to work on palliative care and end-of-life care through advanced care planning or through working with your communities going forward. So Dee, if you could pop over to, go 2 more slides, just to the first of the Stratus Health. There, perfect. I want to take just a couple minutes at the beginning of the presentation just to kind of do a little bit of terminology, housekeeping, because a lot of times I think people use terms end-of-life care, palliative care, comfort care, interchangeably, and they really do have some differences in their meanings, and I wanted to just touch on that before our presenters get going today. When we talk about end-of-life care, we really are talking more about that care that's delivered truly at that end of life, where the person's disease or condition has really become advanced and it's considered incurable, and we're really trying to help that person transition to death in the best way possible that meets their desires and wishes. It does tend to get used interchangeably with palliative care, but I think it's better to think of end-of-life care more as a component of palliative care. Next slide, Dee. Because as we think about palliative care, it really is bigger than end-of-life care. And the way I kind of like to think about it, which is helpful, is if I'm seeing a patient and someone asks me the question, would you be surprised if this person died in the next 2 years? And if your answer was no, that's probably a good time to think about more of a palliative care approach. That doesn't mean that we're not addressing, we may be still pursuing treatment, we may still be pursuing things that could cure, but the overall approach to the patient is really much more of a whole person approach, trying to manage symptoms, trying to get at kind of all the person's needs, not just focusing on that medical condition. So that's what I say, when you think about palliative care, I want you to be thinking about it in a broader scope than just end-of-life care. Next slide, Dee. I think it's also helpful to kind of do the quick look at kind of some differences between the curative model and the palliative care model, because I know many of the folks on the line are physicians, and we really we're trained, and much of the time practice is focused on that curative model. And so trying to think of the palliative model more as a philosophy of how we approach care can be helpful. So these are just a couple kind of compare and contrast that I think is helpful. The curative model, the primary goal is really cure, where at the palliative model, our primary goal can be cure, but it's really relief of suffering. The view of symptoms is also different between the two. Oftentimes in the curative model, we look at symptoms just purely as a cure to what's the diagnosis. That's our tool to say, okay, what's going on? In the palliative model, we'll look at symptoms just as an entity in themselves, and we're okay not worrying what they're a symptom of, but we may choose to treat the symptoms because our overall goal is to keep that person functional or to keep them to meet their overall goals of care. So that means a lot of times our therapy is different in each one. In the curative model, the therapy is often aimed at a cure or slowing disease progression, where in the palliative model, we may be more aiming our therapy at just symptom control. And so then our actual, what we call a success in both kind of models is different as well, or what we call a failure in both models is different. In the curative model, death is really viewed as a failure. In the palliative model, death isn't so much viewed as a failure. What's really viewed as a success is, did we meet this person's needs, desires? Did we match care with what was important to them? And were we able to meet that until they eventually did die? So I think it's helpful to just have that going forward as we listen to the next three presentations. So Dee, if you can move, we can actually pass this one and just move right to the title slide for Bud's presentation. So next I'd like to introduce Dr. Bud Hammes. He is from the Gunderson Clinic and has been very active in the Respecting Choices model. And Dee, you can go to the next slide. I'm not going to read through Bud's bio. He has done just a tremendous amount of work in this area, and I'm so excited to have him on the call, and I think you'll enjoy hearing about the Respecting Choices approach and advanced care planning. So, Bud, I'll turn it over to you.
I have to start by unmuting my phone. Thanks. It's good to be on the call, and thanks for the introduction, James. So I want to talk a little bit about this program that we started in La Crosse, Wisconsin, called Respecting Choices, and I'm going to talk ultimately about how this can help improve care and achieve the triple aim. Next slide, please. we really want to begin in thinking about what is the desired outcome of advanced care planning. Perhaps all too often in the United States, the standard approach to advanced care planning has been the completion of some type of legal document. If you look at the literature and look how people talk about this, it's been the completion of that document which has been considered the kind of outcome or end of the work. I would like to propose that that's a mistake, and that really what we need to consider as a good outcome is ideally to, first of all, know what each individual patient wants, and then to honor that plan. And we achieve that outcome by, first of all, creating an effective plan, and, kind of simply that would include selecting a well-prepared healthcare agent or proxy when that's possible. Not everyone can do that, but most patients can. And then to create specific instructions that reflect informed decisions that are geared to that person's state of health. And I'm going to come back to this person's state of health because we actually think that good advanced care planning should be done in various stages as patients get sick or sicker. But having a good plan isn't enough. The best plan in the world that's unavailable to the treating physician doesn't make any difference. So these plans have to be available to the treating physician at any site of care where that person receives care. And then that physician needs to know how to incorporate these plans into medical decisions when they're needed. And I use this word incorporating into plans because this is a piece of information. This is about the patient's preferences, and there has to be some medical consideration of what the plan meant and how it applies in this circumstance at this moment in time. And that's not always a just straightforward, simple kind of consideration. There may need to be more discussion either with the patient, if they're capable, or with their representative if that's needed. Next slide, please. When we talk about this concept of advance directive, again, very often in the United States, people think of this only as a legal document, but I want to propose for purposes of our program, the Respecting Choices program, that an advance directive is any plan made by a capable person or at times by their surrogate for future medical decisions that address a whole variety of things, including their treatment choices or goals of care. What's important to know is that an advance directive or a plan could be expressed simply orally by a patient, or it could be in writing. And if it's in writing, it could be expressed as a legally structured document recognized in a state statute, or it might be simply something written down more informally, including a physician's note. So in our program, any and all of these ways of expressing a plan is considered an advance directive. Next slide. So what's advanced care planning, which is the other concept that's widely spoken of and used in the professional literature and discussions? Advanced care planning, unfortunately, is often interpreted as the process of creating a legal document. In Respecting Choices, advanced care planning is that process of reflection, understanding, and discussion that we need to help patients go through to make informed decisions about future care. And it's really the quality of this process that really gets us to the results we want. So patients really need to understand and select possible future situations and choices. They need to really reflect a lot, and often what we're finding is that patients really have not reflected sufficiently to make good choices, and this is why we have variation over time in what patients want, because to begin with, they never reflected adequately about what was important to them. And unlike other areas of healthcare where we're getting informed consent or informed decisions, these decisions in particular need to be incorporated to the degree possible with those close to the patient. They need to understand what these decisions are and hopefully come to support them. Next slide. Could you change the slide, please? So So the next slide is about how advanced care planning, or the process of planning, is related to the plan itself. And the simple reality here is the plan is only going to be effective and workable depending on the quality of the planning process itself. Simply put, if the planning process does not have adequate understanding, reflection, or discussion, then there's a good chance that the plan itself is going to fail, no matter how it's passed on or transmitted, whether it's orally or written, whether it's a legal document or a physician's note. If the patient's actual planning process is not of high quality, then the plan itself is probably going to be flawed and subject to various interpretations and understanding, and it's going to create potentially more conflicts and more problems than it actually resolves. Next slide. So this slide actually depicts what we think and have come to learn are the stages of planning over the lifetime of adults. So in the yellow here, we have what we call first steps planning, and you can see at the bottom that this is really targeted to healthy adults between ages 55 and 65. Now, those dates might have some disagreement about exactly when we would start this, but we're really focused on adults who stay healthy into their kind of late midlife. And here we want to create a power of attorney for healthcare, and then consider in this, after appointing a well-selected healthcare agent, when a serious and permanent neurologic injury would be so bad for this individual that the goals of treatment should change. I would add here that we would certainly plan and want to plan with someone who's younger and develops a serious progressive medical problem, so we wouldn't exclude those. But this planning, while very important as a beginning point, often needs to be followed for most people later with what we call a next steps planning process. And here we have adults who, are kind of in the early last 2 years of life, and they have a progressive life-limiting illness and are starting to suffer frequent complications because of the progression of their disease. It's just harder and harder to manage, so they may be in the hospital frequently, for example. Here, the goal isn't so much to move them into kind of end-of-life care or hospice care, but really to determine when the goals of treatment should be followed or should be changed if complications result in a bad outcome. So a person with congestive heart failure who now comes in and we aggressively treat them, but they suffer now a massive stroke, would have a bad outcome, and we might be able to keep them alive, but this planning would help us sort out whether that would now be the goal or not. And then finally, we have last steps, and here we have a person who we wouldn't be surprised if they died in the next year, despite our best efforts, because of the progression of their disease. And here we would want a very specific medical plan expressed in medical orders, and in most places now this is going to be recorded and documented on a post-paradigm form, which Dr. Cohen is going to talk about next. Next slide, please. Now, the importance of or the possibility of having this stages of planning and this high-quality planning process and having these plans available really only becomes possible if we develop a system, and that's what I want to talk about. And I want to use this example that we're all familiar with, which is calling a code blue in the hospital when a patient who's a full code suffers a cardiac arrest. We're all familiar with this system of what happens in the hospital. A CPR is started, a phone call is made to a specific dispatcher or operator, a code team is then notified, the code team responds, they go through the ACLS protocol, and this whole system is monitored and managed by a resuscitation committee at the hospital. We're all familiar with this microsystem in the hospital, and we all would recognize that if you start taking away parts of the system, take away the operator, take away the train for ACLS, the whole system would start to collapse, and the outcomes would be poor. Unfortunately, what we've been trying to do in most places in the United States is have good outcomes for advanced care planning without any organized system. And I would just submit that that's impossible. And no matter how many brochures we hand out, how much publicity we give, no matter how much education we do, without an organized system, we will continue to fail. The success that we've achieved in La Crosse and other places now across the United States has occurred because we start with the development of a specific, well-designed advanced care planning system. Next slide, please. So can we, and then go to the next. So what might a system look like? Well, we've come to realize that there are 4 key elements in designing an effective system. There's system design. This includes medical records to capture and retrieve advanced directives, standardized documents. We've created this new role of a facilitator, so we train people to have these conversations. Most of these are non-physicians. Some of them are volunteers. Some of them are social workers or chaplains or nurses, but they have a specific role and they're trained to facilitate conversations and are given time to do that. In the best systems, it includes community education engagement outside of the healthcare setting at churches and through county health departments and other kind of venues. And all of this is managed by continuous quality improvement. So every system we have designed here in La Crosse has initially did not measure up to what we needed, so we redesigned it, we remeasured, we redesigned it, we remeasured. And a good part of the success here in La Crosse is getting started on the right track with the right concepts and the system and mentality, and then continuously improving it over time. So we have achieved the outcomes of have 96% of La Crosse County residents having a written care plan in their medical record at the time of death. Next slide, please. So having a system means that we have to devote some of the same organizational resources and efforts to advanced care planning as we do to, say, ACLS or even infectious control. This means that we have to have sustained institutional resources. Typically, this means having some kind of coordinator overseeing the work and an oversight committee, that we need to design processes and select tools and materials, define roles and responsibilities. So everyone needs to know what they have to do in their job, doctors, nurses, and so forth, and then how they do those jobs and how they need to be trained them, and then we need to measure the effectiveness of the processes as well as the outcomes of the system, and then continuously improve what we do until we start to achieve these kind of outcomes. Next slide. So what can we expect if we have a well-designed system? How might outcomes change? Next slide. Well, this is a demonstration of the retrospective studies that we have conducted here in La Crosse County, population of about 110,000 people now. We started this system design in 91 and 93, and we did our first measure of all deaths in all settings of care in La Crosse County in 95 and 96. At that time, after 2 years of full implementation, we had an 85% of people having a written directive at the time of death. 95% of the time these directives were in the medical record where the patient died. And when we looked at refusals of treatment in these directives and medical orders at the time of death, we found a 98% consistency. We remeasured the same population, all deaths in La Crosse County. It was a shorter time period, so only 7 months versus 11 in LADS 1. And now we had a 90% prevalence of written plans. 99% of these, we captured them in the medical record at the site or organization of death. And in the second time, we looked at both requests for life-sustaining treatment as well as refusals of treatment, and we had a higher prevalence or consistency between preferences and treatment provided. Next slide. In our community between LADS 1 and LADS 2, we introduced the pulse paradigm in our community in 1997. La Crosse region is the second longest use of pulse in the country after Oregon. In the same population of 400 deaths, 67% of the people had a pulse document. Most of these also had a power of attorney for health care. The pulse document was found in the medical record of the right institution where the patient died nearly 99% of the time. These pulse documents were typically completed and signed by the physician about 4.5 months prior to death. That's the mean time. And that if we asked, did these decedents have either a pulse or an advance directive, we found that 96% had one or the other at the time of death. Next slide. Can you do this at other places? And what if we did this in a prospective trial? That was done in Australia using the Respecting Choices model. You see the reference at the bottom. If you could go to the next slide. So this was done with 80-year-old patients, and they found some very interesting things. First of all, the patients who were involved in this intervention were far more satisfied with their hospital care than the control group, despite the fact that these patients were cared for in the same nursing units by the same doctors and nurses. So anyone who says that advanced care planning is upsetting the patients is going to have to explain this data, which was done in a very carefully controlled randomized trial. And the people who collected the data were actually blinded to which group the subjects were in. Next slide. Well, what was the outcome? Well, two important outcomes is, first of all, the people in the intervention were more likely to have plans and have their wishes followed, but more importantly, or as importantly perhaps, the family of the intervention group had lower distress scores, the impact of event scores, a distress score, and the patient's family also had less depression, and I don't put this on the slide, but less anxiety. So this had great benefit for the patients as well as their family who got this advanced care planning intervention. Next slide. This model has been extended to other places, such as Australia, Germany, and Singapore. We have projects in Iowa. There's a huge metropolitan intervention in the Twin Cities called Honoring Choices, Minnesota. We're rolling this out in Kaiser Permanente of Northern California, a health organization that cares for over 3 million people, and the state of Wisconsin through the State Medical Society called Honoring Choices Wisconsin. So
this is Jane Peterson. I'm going to ask you to wrap up because we have to move on, and maybe what we can do is at the end we can touch on some of your last slides about the AAA. Okay,
that'd be fine.
Okay.
So you want? So I'll just wrap up here. So these matters do. These end-of-life discussions clearly do matter to both how patients fare as well as their families fare. And again, this is achieved, I think, only effectively through a systematic application in redesigning how we care for our patients. And then we'll return to the kind of triple aim outcomes at the end. Thank you.
Thanks, Bud. We're going to move along next to a discussion of the pulse. So, Dee, if you can flip to the slides there, and then just go ahead and go to the next one. Hearing from Dr. Richard Cohen from Georgia, and he's going to be talking to us about implementing the pulse in their state, some of the barriers and successes. So, Dr. Cohen, I'll turn the floor over to you.
Good morning. I'm glad to be here. If we can go to the next slide. And I want to really reiterate what Bud is saying all along. And the pulse is an integral piece, but like everything else, it's really not advanced care planning. Advanced care planning is not an event, it is a process. And I think we need to, again, exactly where Bud is, it's a process, it requires dedication, and it requires a system. Next slide, please. So really we're talking about a continuum. Advanced care planning, as Bud has said, is a process, but also it's a conversation, and it's a conversation between a patient and their family, between a patient and their siblings, between a patient and their spouse, and including a physician as well. Because the better understanding is that it's had by a physician of his patient's needs prior to an urgent situation, the more likely it is that that physician will help and ensure that other physicians will honor those wishes. Advanced directive, as we stated, is a document, And that is all it is, but it does express a person's wishes for their care at the end of their life. A pulse is a physician order for life-sustaining treatment. It is an order that activates an advance directive and usually is of one page only, and it is not to be used as an advance directive. Next slide. This all started back in 1991. It started in Oregon when leading medical ethicists discovered that end-of-life care really wasn't being consistently honored and really wasn't even being discussed well. As a result, this became a national movement, and many states started to work to tailor a paradigm that would fit their unique legal, medical, and cultural context. It's complicated, as they say. Next slide. The initial program started in New York, Pennsylvania, Washington, West Virginia, and with Bud Hamas in Wisconsin. Each of these states has had to take a somewhat different view, if you will, or different course. And that's because there are laws that interact with all of this that we're talking about. Excuse me. And that those laws vary from state to state. So there has to be a customization, if you will. We can come up with the same document, but how you implement documents is different. In 2004, the National Pulse Paradigm Initiative Task Force was convened by many people of great note, and particularly, again, Bud Hamas. Right now, there are 16 endorsed states. Next slide, please. And there are about 16 to 20 that are continuing to work on the process. The two very dark states here are very advanced states. The ones that are sort of a heavy pink are those that are now endorsed. And these states have really gone through multiple steps and are all also in process of moving toward the mature Oregon, West Virginia status, which is a more mature factor, and in fact, really it shows a development, much of what Bud is talking about, with systems in place, with less a focus on the document as much as the system, how to use a pulse, and how to get that pulse honored in an appropriate way. Next slide. In Georgia, we started using the pulse at Wellstar Health System, which is my health system, in 2007, and then across the state in isolated hospitals, functioning really very independently, the pulse started to get a little bit of movement and a little bit of introduction into certain areas of the state. But it had no coordinated way, and if a patient in one area of our state had a pulse and were to go to another area, 9 times out of 10 they wouldn't have an idea about what we were talking about or what the pulse really meant. Next slide. So the goal in Georgia is to create a medical order completed by a healthcare provider, a mechanism to communicate a patient's preferences at the end of their life, and is designed to travel with a patient from one setting to another. Next slide. How to go statewide. That really became the challenge. And very honestly, a group of us started traveling the country, went to Oregon, went to Wisconsin, talked to people in New York and Pennsylvania to try to get an idea how to implement such a program. Georgia Health Decisions is a 20-year-old organization statewide in Georgia that has been dealing with issues of end-of-life care for 20 years. They hooked up with what we were doing at the Wellstar Health System, and we started to think about how to get this going. And in 2010, we started to evaluate which was the best process. You could either, one, try to create a statewide practice, if you will, that was the best practice that everybody sort of signed on to, or the other option was legislative. Most of the states have gone the legislative route, and we felt that was appropriate for us. Next slide. As a result, we went to the legislature, and as I said, it got ugly in a hurry. It all was going well at the beginning when we started the process legislatively, and then two groups opposed the bill. The bill was pulled. And then at 11 hours and 59 minutes, somebody was nice enough to slip in the following paragraph in an unrelated bill. It stated the Department of Human Resources shall develop a pulse form to be signed by a physician, a patient, and a patient representative. Remember the and. Next slide. 2011, nothing happened. 2012, things started. Next slide. 2012, the Department of Public Health said that they would take on this responsibility. They called a task force made up of about 12 leaders of different organizations around the state, and we came together and spent about 5 months working with the department on the development of the concept of a state pulse and what that pulse would look like. And then in July of 2012, the pulse was published by the Department of Public Health as a statewide document to be used uniformly across the state. And that document was posted on their website so that all could use it. And in addition to that, we also developed an immunity piece that went back to the legislature and got an immunity, and that immunity said that any person with a pulse who applies to a pulse form, their immunity is provided so long as for any person acting in good faith. Remember the word person acting in good faith. Next slide, please. This is the form that we're using in Georgia. It is very consistent with the form that's being used nationally by the National Pulse Movement. There's tiny little verbiages that we're still working on, and it's a continual updating process. If you go back and look at the initial pulse form of 1991 and track it, you will notice that every few years that form has changed and has matured and has improved. It's not a static form, but it is a dynamic form that does change on a periodic basis, and we're trying to do that in Georgia as well. Next slide, please. So the Georgia Pulse Form, like all pulse forms, has 5 sections. The first deals with cardiopulmonary resuscitation and your wishes there, medical interventions that you may or may not want, antibiotic usage, artificial nutrition and fluids, and then the signature portion and the reason why. In other words, who did you talk to about this information and gain this information in order to fill in the information in the pulse form. And then the signatures. And the signatures have become a little bit of a problem. Next slide, please. So who should have a pulse? Back to the statement that Bud was showing you, anyone who might die within the next year. That, to me, is the key piece in a pulse. So if your answer is no, I don't think that person's going to die in the next year, then probably a pulse is not the best thing or the best vehicle. But in fact, a conversation and an advanced directive and an advanced care planning process is really the appropriate thing, not a pulse. But anyone who has a significant chronic condition and who is in the last year of their life should have a pulse. Anyone choosing to allow natural death, which is a term that we're using in Georgia, rather than the term do not resuscitate, and many other states are starting to incorporate that term. A little better use of choice of words than do not resuscitate, allow natural death as a much better comfort measure, more comforting statement when you talk to a patient and family. And anyone choosing to limit interventions really may be a person for a pulse. And anyone residing in a long-term care facility. And that's an area that we're spending a lot of time in Georgia with, because those are patients who most often are, in fact, in the last year of their life. Next slide, please. This is sort of how we've looked at this across the state as we've moved forward. We have the patient at the bottom in the center, and we've been working in the hospital for years. And what we've come to realize is that's the wrong time, wrong place. Because this is a time of stress, patients are making bad decisions or forced to make decisions under duress. So we started working and moving the entire advanced care planning program and pulse out into physicians' offices. And we're educating our physicians to be able to have the conversation with the patient and to be able to start the advanced care planning process in the office and hopefully to complete it in the office and then place it in the electronic medical record. We're also moving out into our hospital service area. So we're moving into long-term care, assisted living, subacute units, home health, and hospice, and supporting them throughout our area with information on advanced care planning and pulse, which then brings us to the state. Is how do we get this so it really works on a statewide basis? And that's where we were very fortunate to finally get a group together to create the pulse on a state basis. Next slide, please. And that, with the creation of the pulse, we were now really able to create the Georgia Pulse Collaborative. And we have over 30-plus statewide organizations, from academic institutions to hospitals to the law school to state agencies to long-term care groups to the physician groups, the hospital groups, and associations and the like. As a result of that, we were able to coordinate with the national movement and became an endorsed National Pulse Paradigm Task Force member because of the efforts that we've done. And quite honestly, with Georgia Health Decisions and WellStar and Piedmont Health System and other organizations, we had a head start, and we've been working on this for the last 5 to 10 years, but in fact didn't have a coordinated mechanism. Our collaborative has a vision. All Georgians have their health care preferences known and honored. Next slide, please. We have a mission. Next slide. We have a mission statement to improve health care at the end of life through promoting the utilization of the pulse and educating Georgians on advanced care planning and the role of the pulse. Next slide. Next slide, please. So the collaborative has been structured with a series of committees, education committee, budget committee, and committees of that nature. We have 2 major pilot projects that are going on in our state, one in Macon and one in Savannah. We have spread this effort through the hospital system, through governmental agencies and academic institutions working in coordination with their particular group of people that they work with. And we've had a great deal of support from the Alliance GMCF, which Dr. Mims is going to talk to you a little bit about as I finish. Next slide, please. But, and here's the but, we've still got issues, and we have issues statewide. We don't have a good law that says it's transferable. Remember that word "and"? It required 3 signatures. We had to go back and get that corrected in the state legislature. Again, we removed the "and" to an "or." The immunity, we forgot providers and institutions, so we've had to go back and amend the law accordingly. We have compatibility issues with the CPR law that exists, and our Department of Community Health, who supervises long-term care facilities in the state, still has issues about signatures, and we have some problems there that we are in the process of resolving as well. So it's an ongoing process as we move forward with education in an effort to move across the state. Next slide, please. And the last piece that we're concerned about is that the Hospital Association, Medical Association, is worried that if you're a physician and you have a pulse in front of you and it's signed by a physician who's not a member of your staff, then how do you handle that? And we're handling that. We're going to go and deal with that by either regulation or legislation. And very honestly, we're going to do it by regulation from our Department of Public Health. And it's going to say a statement something like, the fact that a physician-assisted nurse practitioner who executed a life-sustaining treatment order does not have admitting privileges to the hospital or healthcare facility where the patient is being treated does not remove the obligation to honor that order. And that, to us, is going to be one of the mechanisms we're going forward with this year, and the Department of Public Health has said that they will support in this effort so that we can get compliance and transferability across the state. I thank you for your time. I'm glad to answer questions, and Dr. Mims, I know, wants to add a few sentences as well. These are the websites that we promote across the state as well.
Great. Thank you, Richard. I appreciate you giving an overview of what we're doing here in Georgia for the Pulse. I would want to relate this to specifically how this is part of our current 10 scope of work. Many of us are working in the area of C8, reducing readmissions by improved care transitions. And in Georgia, we have an ongoing dialogue among different communities called Community Healthcare Connection Meetings. Next slide. And in those Community Healthcare Connection meetings, we do root cause analysis as to what are the reasons people were having challenges with readmissions. And time again, the challenges have been advance-directed. And so we have been working as one of those organizations that are part of the Pulse Collaborative. And Richard, I really want to appreciate that you showed that state so that those on the line can see where they are with the implementation of that. Lastly, I wanted to say that can we put out phones on mute in the background? And lastly, I would like to say that we received a funding from CMS for a special innovation project to implement Pulse in 2 communities throughout the state, primarily in hospitals and the nursing homes in those communities. And we'll be able to share more on that after the end of the presentation. So, Jane, I'll turn it back over to you.
Thanks, Adrienne. And Dee, if you could go ahead to the Stratus Health slides, that would be wonderful. I just want to take a couple minutes just to, really it's kind of the slides and how I met Dr. Benson, but a little bit of background on the rural community project that we did at Stratus Health, because I think it helps put a context for some of the things that you're going to be hearing from Dr. Benson. Next slide, Dee. At Stratus Health, we had the great opportunity to get some funding from one of our local care systems, UCare, to do some work setting up rural palliative care programs in rural communities. And the reason we chose that is we realized that a lot of palliative care and palliative care programs was really done at the inpatient. But we have a large rural state, and a lot of people in the rural communities really weren't getting palliative care services because they either had to leave their community or travel in order to do that. And as we looked across the rural communities, you can go to the next slide, Dee, there was already a lot of things in place that really were well set up for doing palliative care. We had physicians trained in primary care. We had, it was just a matter of maybe there's extra training that some of the providers needed, but there was already good networks in place between the organizations in these rural communities. So next slide, Dee. So what we wanted to do in this project is to just assist these rural communities to strengthen or establish their palliative care programs. And so we did that by bringing together the communities in a real structured approach, and we did what's called community capacity development. Next slide, Dee. So we did this through the fall of 2008 to the winter of 2010, and you can see the strategies listed there to learn this collaborative approach, focus on the capacity development, and to really set up some multi-setting, multidisciplinary teams. And if anyone's wanting to dig more into that, you can see the website for our final report. Next slide, Dee. And for those of you who don't know, this is Minnesota. We're one of those big states up in the top. I always have to laugh because being Minnesotan, sometimes we get all those little small states out on the East Coast mixed up. But these are all those cities in Minnesota that have been part of our rural palliative care work. Next slide, Dee. And this is just kind of the equation or formula that we use, and I think you may kind of hear some of that come through in Julie's presentation, but really to kind of get that stakeholder approach use those national standards, intervention models, bring the community together, and then that resulted in a real custom-designed, community-based palliative care program. And so next slide. And so we're really happy to say that really we've had great results with this. Of our initial 10 communities, 6 are really providing palliative care services, and we've even got some processes in place for health plan contracts to pay for palliative care programs. So it's been a really exciting program. I thought it'd just be helpful to give that as a little bit of setup before I turn it over to Julie. So Dee, if you could flip to the first slide with Julie's picture on. So next I would like to introduce Dr. Julie Benson. She is a fellow Minnesotan and works at Staples, Minnesota, and she's going to talk to you specifically about their rural palliative care program, some of their successes, barriers, and what they've learned along the way. Julie, I'll turn it over to you.
Great, Jane. Thank you very much. Next slide, please. And the next slide, please. So I'm going to talk a little bit about sort of the basis of why we do this. And this really, this slide I start all of my talks with, just to remind us all about why many of us are in medicine to begin with. To cure sometimes, to relieve often, to comfort always. This is our work, and this is our mantra as well. Next slide. We'll talk a little bit about Lakewood Health System, which is where I'm employed. We are smack dab in the middle of the state of Minnesota. We are a population of just under 3,000, our town is, but we service around a 38,000 area based upon 4 counties. We are a critical access hospital, which means we are licensed for 25 beds. We're also a rural health clinic. We have 5 clinics, which include our main Staples and clinic, and then 4 other satellite clinics, some in towns as small as 300. We have senior services, which includes long-term care of about 100 beds with a secure dementia unit. We have 2 assisted living facilities, a behavioral health unit that's licensed for another additional 10 acute care beds, home care hospice, and ambulance services. Next slide. This is just briefly to explain to people a little bit out there what our medical staff looks like. We are really primarily centered around primary care and 15 family physicians. When I took my job here 16 years ago, I was one of 7 family physicians, and we had 1 PA. And we have certainly grown over the past few years. Next slide, please. This is one of the definitions that I like to use about palliative care. There are certainly many different definitions out there. I try to remember that palliative care is about relief of symptoms, information for family and patients, the options of choice, trying to give them as much control as possible, and really to continue the care with with the people that they want to continue the care with, whether that's at home or in a tertiary care center. Next slide. Next slide, please. This paradigm is what I believe palliative care should look like. And over the years, I've given different talks about palliative care. This slide changes, and probably about every 6 months, I could probably add to it a little bit as I change how I look at palliative more and more upstream. My belief right now is that when there's a diagnosis of a potentially life-limiting illness, life-limiting disease, that we really need to start thinking at this point in time, is it appropriate for palliative care? And not just because the definition, which I also use, which is would you expect this patient to die in the next 2 years, is not appropriate, but I think we often think about care as linear, and sometimes really palliative care needs to be run in parallel too. So usually at the time of diagnosis, there is often some crisis. It might be the time when someone is told they have a stage 3 cancer. It might be their 4th admission into the hospital for congestive heart failure. And maybe nobody's really sat down with them before then and said, you know what, this really is a life-limiting disease. We really need to look at what's going on here with your heart. And then over the period of time, you'll see that there are sort of acute exacerbations of when we might be focusing more on curative or palliative care, depending on where things are at. Palliative care should not necessarily be thought of just as pre-hospice, which I think a lot of people still think of it as. And then palliative care really does extend beyond death into continued bereavement support, and we take that very seriously here as well. Next slide, please. The birth of palliative care at Lakewood started back in 2005 when actually our definition of palliative care was just that, pre-hospice. Some hospice nurses said to me, we need to be giving care to these people who don't want hospice yet or who aren't ready for hospice yet. I think we've all heard those terms before. And so we decided to use our hospice team, and we admitted them to a palliative care program, and that seemed to work out very well, but we knew we were not servicing enough people. And so over the course of the next few years, there was sort of a grassroots movement to develop more comprehensive care to people with severe chronic medical illnesses. We were lucky enough to receive some grant money in 2007 and 2008 that began our developmental process. And then we were chosen by Stratus in 2008 to begin the Minnesota Rural Palliative Care Initiative that Jane talked about earlier. Through that, we were able to develop some pilot programs. We started with 5 patients in our infusion therapy program and 5 patients in our care center. We have grown over the period of time to an active outpatient and care center population, and we also do inpatient services as well. Next slide, please. So in the fall of 2008 through 2010, this really is the same exact information that Jane presented, so I'm going to have you move forward another slide. And this is to talk a little bit about where we provide care. We provide care in our long-term care setting, which is part of our hospital system here. We provide interdisciplinary team meetings, consultative services, and ongoing support. We provide palliative care through home care and hospice. We provide it through outpatient services, which is, again, interdisciplinary team meetings, telephonic support, and home visits, and then also inpatient consultative services, supportive care, and particularly help with transitions of care. Next slide, please. Our interdisciplinary team here, we are quite blessed. We have 2 RN case managers, a social worker, a chaplain, our pharmacist, myself as the medical director, a mental health provider, palliative care team coordinator, and we have some spiritual volunteers. As necessary, we bring in our medical home nurses, home care nurses, long-term staff nurses, and other therapies. Next slide, please. To develop this program, we really spent a fair amount of time looking for different models of care, and what we found out quickly was that rural models of care did not exist at the time. There was really very little out there, and so we looked at this as a blank slate and said, okay, we can do whatever we want. For us, palliative care was really a belief in an ongoing process and not just episodic consultations. We certainly do those, but we really wanted to provide ongoing care along the journey and along the continuum of this disease process. So we've kind of selected the hospice model of care. It provided interdisciplinary team meetings every 2 weeks. We developed plans of care that are updated in the electronic health record on a regular basis. We keep the attending provider as the main provider during all of this, and then as medical director, I serve as sort of the backup. I also serve as sort of a consultation services if there's a complex care or other needs available. And then there are really no CMS guidelines to follow certifications, and so we have some flexibility of care as well. Next slide, please. There were 4 main strategies that we looked at building our program. We had to have administrative buy-in. And for us, that was not very difficult. We have a very supportive administrative team here. We needed to develop our team, which I've already explained to you above, with a case manager. We needed to educate a lot of people. We needed to educate medical staff, nursing staff, patients, families, the general public, and that for us is actually an ongoing process. We continue to do education out in the public as well as educating staff needs as they turn over. And then we really built our skeleton upon the 8 domains of palliative care, and these are based upon the National Quality Forum consensus guidelines, and I have that resource for you at the end of my slides. These are the 8 domains of care, and specifically they look at physical, psychosocial, spiritual, cultural aspects of care, as well as legal and ethical. Next slide. When we went to our administrative team to talk about the support that we might need, my CEO essentially said, go for it. And this is why. This is really about our mission alignment. There was nothing in palliative care that did not go along with what we truly believe we are meant to do in this community. And we have a very forward-thinking administrative team, and they really are trying to create the change that we want to see in healthcare. And this goes really along with healthcare reform as well. For us, being a critical access hospital, the financial incentives that are frequently cited for palliative care about saving money, decreasing lengths of stay, decreasing ICU days, decreasing expensive procedures really are not a main motivator. And in fact, for rural hospitals and clinics, this is actually a detriment to us because we are paid on a cost plus. So we get paid what it actually costs us to take care of patients, not based upon DRGs necessarily. And so for us, if we have decreased lengths of stay, that actually means decreased money for us. But we all know that with healthcare reform that this is not going to be the eminent way we give care. We know that we are going to be looking at total cost of care, and different hospitals and systems are going to be responsible for that based upon really the healthcare reform that we see coming down the line. Next slide, please. There were other financial considerations to actually developing it now, though, in a fee-for-service venue, which is what we live in. And so our charges are based upon normal face-to-face care in the clinic, hospital, long-term care, or home. We were lucky enough to secure a contract with one of our local insurance companies, UCare, and they actually provide us with some monies for the unbillable visits typically seen by RNs, social workers, and chaplains. We've been using this contract then to have conversations with other insurance companies, and we are also using some of our quality data to prove better care for our complex patients. We have been having conversations with the VA as we are outside of their general 40-mile radius, and so they need to provide care to patients outside of the radius that they serve, and that really falls into all of rural Minnesota. And then along with our medical home program, we are seen as an example of some of the quality of care that Lakewood Health System is moving towards. Next slide, please. So the services that we provide include in-home admissions whenever feasible, and that's really meant for our staff to sort of get to know the patient and their family. It is not necessary. Sometimes our admissions will take place in the hospital. Sometimes they'll take place here in the clinic, perhaps over an infusion therapy. Once they are admitted, we sort of develop a level of care that they may need. And it may include telephonic support with proactive as well as responsive calls. We support them in the clinic and with specialty visits. Sometimes my nurses actually accompany patients who have no family in this area and help them sort of process what the specialist said to them about perhaps their cancer or their end-stage renal disease. We provide support in the emergency department or inpatient units as needed. We definitely provide support through transitions of care. It is not uncommon for us to hold family meetings. We are very active in our advanced care planning, and we also use the pulse order set here. All of our patients in our care center have a pulse, and any of our patients who are likely to die in the next 12 months, and they understand it, have a pulse. So not all of our patients have a pulse yet. Some are not quite to that point. Next slide, please. The data that most people will look at when we talk about palliative care really derives from large tertiary care centers. Most of them are inpatient centers. So there's not a lot of outpatient data, and there's very little rural data on palliative care. So we were lucky enough to be involved with Stratus Quality Measures pilot, and we have actually been collecting some early data. So I'm going to show you some unpublished data in the next 3 slides. Next slide, please. This first slide is the number of emergency department visits. The light blue is our patients based upon 6 months prior to them becoming involved with our palliative care program, and then the dark blue is the 6 months after, the quarter after they've been involved in palliative care. And you can see that we have cut emergency department visits in half. A lot of this is regarding symptom management. Some of this is about just anxiety and trying to figure out what to do next. And if we have some options to get them involved in the clinic versus going to the ED, we have some ways to cut our ED visits as well. Next slide. This looks at the inpatient stays. Again, light blue is 6 months prior to involvement with our palliative care department, and then the dark blue is after their involvement. And again, about a 50% reduction, just kind of eyeballing it. Next slide. And then this is number of inpatient days. And one of the other things that we've found is that we actually have more than a reduction of by almost 70% in number of inpatient days. If we can get involved with people, we can help develop plans of care, we can help develop goals of care that are consistent with their advanced directives, or maybe they don't even have those set up, we can actually help transition faster to perhaps a care center or back to home. than if we were focusing just on curative treatments. So this data for us has been actually quite eye-opening, and we're using some of this data to help with our negotiations with other insurance payers as well. Next slide. And I'm just going to briefly show some work that I've done with ICSI, the Institute for Clinical Systems and Improvement. They have really developed this idea of bringing palliative care a little bit more upstream. This is Lily. Lily is living with a life-limiting illness every day. And this still puts palliative care more into a linear and progressive paradigm here, but I do like the components here. If you can take a look, it talks about shared decision-making, opportunities for collaborative conversations. All of those things happen after the time of diagnosis, and I think that's a really important way for us to view things. And next slide. So I'll finish with you matter. Because of who you are, you matter to the last moment of your life, and we will do all we can not only to help you die peacefully, but also to live until you die. And that's really what we try to focus on here. When we talk to patients about palliative care, we do not talk about necessarily just about end of life. We really want to talk about getting some of these hard things done ahead of time and then allowing people to live. I have one patient right now who's done a ton of the hard work. She's been diagnosed with stage 4 breast cancer. She's incredibly active. She's done all of her stuff that she needs to do, and then she just told one of my nurses the other day, I guess I have nothing left to do but live. And she is definitely doing that, and she's enjoying all this, and she feels like she's kind of got her homework done, and she's now on summer vacation, and she's getting to enjoy all this. And I really wish that everyone would have that opportunity. I thank you for your time, and we'll move on now to the next section.
Thanks, Julie. This is Jane. Boy, I think all our presenters need to just take a breath. You got a lot of information out in a short period of time. I know Bud has a couple things that I'd like him to finish up, but let's maybe just take a break from the presentations and see if there are a couple questions out there toward any of our presenters at this time. So I don't know. I believe if you *6* your line, you come off mute. If I'm wrong in that, dear Adrian, please correct me.
Jane, you're correct with that. And people can also write in questions into the chat box. But to get us started, I had a question that several of you can answer because it's regarding Pulse, and you all the panelists have had some experience with the Pulse. Can you talk about more what support is available from the national Pulse.org in many of the states that are not dark pink or even white on that map that was given before?
This is Bud. I can probably answer partly that question as I serve on the executive committee for the National Pulse Task Force. There is a consultation committee which will give advice about how to get started, how to form a kind of oversight or steering committee. There's opportunities to talk with folks who understand some of the legal issues. And we have Charlie Sabatino from the American Bar Association as one of the advisors to the task force. So there are many opportunities both on the legal, the emergency services, system design, and so forth that the National Pulse Task Force would offer. And I would just suggest that if people want that advice, they would go to the www.pulse.org and make an inquiry, and someone from the national office would be responding to that, kind of assessing what you need, and then devising a kind of response to your needs.
Thank you, Richard. Did you want to add to that?
Yeah, I'd like to add and support again. I think all three of us have been saying something that is very similar and I think needs to be reinforced to the extent that we're talking about processes, we're talking about systems, and ultimately really what we're talking about is a significant change in culture. If we think about the three people on here and their education and what they've learned today, the cultural change is very dramatic. In order to get this working in any given community, or any given organization, it requires a great deal of time, and it really requires a significant champion. You've got to have one or two people who are willing to stand up and to go forward, like Dr. Benson, and go into her area, her community, and get the support, and then have the vision to move forward with it. It's really not so much collective as really oftentimes it is somebody who will champion the effort and take the time.
And there was a question in the chat box directly for Dr. Heyman. What was done in La Crosse County to educate the physicians and get their buy-in to support Pulse? And I'm sure, Richard, you'll be able to answer that too.
Well, you know, first of all, I just have to admit La Crosse County's and the region is a little bit unique is because we have two major health systems. One is a male health system affiliate, and the other is Gunderson. And we both have all of the physicians are employed, so we have a huge advantage over many places in the United States. But to kind of go to Dr. Cohen's point, this is cultural change, and there has to be education about what the pulse form is and how you use it and all of those kind of things. But in reality, I find that many physicians who are caring for these patients in the nursing home, in hospice programs, even in the emergency room, once they see the system work and they see how it can improve the care of the patient as well as reduce the time it takes for them to interact with families and make decisions, getting physician support may not be as hard as you might think, but physicians actually have to witness and see this as part of their work in order to believe that it actually is an improvement.
Does anyone else have any comments on that?
Especially from Julie, since you're dealing with this in a community.
Sorry, I didn't realize my mute button was still on. I absolutely agree that one of the benefits that a mature palliative care program can offer is time. One of the things that I'm able to offer my partners is my schedule has allowed me to carve out some time to sit down and have some of these conversations in the hospital when they're being pulled in 3 other directions. And I have a team of people. It doesn't always have to be myself doing this conversation. I have a team of people who can really set the stage, help families come through this. And it's not uncommon for me to be pulled into a family meeting, and most of the work has already been done through chaplaincy, social worker, RNs, who really know the verbiage. They know how to gently guide families. And so lots of times that's really one of the major benefits that we can offer other providers. We're going to be pushed to do more with less time, and we really need to use our support staff to the fullest capacity of their licensure. And I think palliative care is a great model for really letting people work to the top of their licensure.
Thanks, Julie. Anyone else have any questions at this point?
Well,
remember *6 and you'll unmute your line.
While people are chiming in, let me ask a couple other questions about palliative care. And I know there may be some difference from rural to urban, especially since in which you mentioned, Julie, you took a hospice approach. Is palliative care something that is easily covered by most insurances, including Medicare, Medicaid? And what is the training or background of those individuals?
Those are 2 great questions. I'll answer the easier one first. The training and background for most people, as of last year, was the last time that you could take boards without going through a fellowship to be trained in hospice and palliative medicine. So I was able to come in through the board certification process just through experiential care. Now, afterwards, we are going to have far fewer people board certified in hospice and palliative care because you now need to be fellowship trained, and there are just not as many fellowship positions available as there will be a need for this. And so one of the other pushes that I'm hoping people will see the need for is that primary care is uniquely situated to really do primary care, palliative care, and we need to be teaching our students, we need to be teaching our residents about palliative care and end-of-life care. When all residents are required to do at least 4 weeks of obstetric care, and that really is, for 50% of the population, is at risk for becoming pregnant ever, and yet we have no 4-week requirement for 100% of our population is at risk for dying. And I really think we need to bring this back to that education piece, and I'm working with medical students and residents as well, trying to focus on that. From a payer standpoint, that question is much harder and much more complicated. Right now, most insurance does not necessarily recognize palliative care in and of itself, and particularly the way that we do it. If they pay for home care, then I use a home care-based palliative care program, which is with my home care and hospice nurses. If they are not homebound and the insurance company does not pay for palliative care other than face-to-face service like I can provide here in the clinic, then we essentially do most of that sort of out of our budget. Most of it's phone calls, and my partners in this team are employed by the system. But we hope that as healthcare reform changes, and as we're really looking at episodes of care and not just fee-for-service type care, that we'll see better reimbursement for it. Medicare, Medicaid do not specifically look at this. There are some insurances who do specifically carve out some palliative care type reimbursement, and that is really based upon certain negotiations. And so right now, that's a difficult question to answer across the country.
This is Bud. Could I just add to that comment a little bit? Gunderson has undertaken a CMS demonstration project to provide an ambulatory palliative service that combines palliative medicine, care coordination, and our next steps, advanced care planning, into a welded team that works together for all patients with a life expectancy of about 2 years. These patients we identify in this demonstration project proactively, so we don't wait for physicians to refer patients to us. We tell physicians they have patients who are eligible for this service. The patient continues to see their primary care physician, and this team supports them to try to achieve many of the outcomes that Dr. Benson. And CMS is actually paying us for the service on a per-month per-patient basis. So we wait to kind of develop this, and hopefully the outcomes of this CMS demonstration project will continue to push CMS to actually reimburse providers for this kind of service.
This is Julie again, and I completely agree that there's a lot of demonstration projects like this going on around the country. So the answer to that question is really going to be revealed over the course of the next handful of years. And there's a ton of stuff going on that is really quite exciting, and I'm going to invite you to keep your eyes and ears open regarding that.
Thank you. And last question I had was regarding the role of end-of-life, palliative care, and the long-term care setting. What are the special considerations that you're noticing?
This is Julie. I'll just take how we look at it. Right now, the special considerations really are most people who are in our long-term care centers, unless they're there for rehabilitation and then to be discharged home, really have come along a journey of needing increased care. And so for most of them, these conversations are not much of a surprise. Some of them they are. And we start this process really on admission, whether they're new to the facility and have not had their health care here in the area, or whether they are from directly from this area. When they come in, we start these conversations, and we have found that the conversation, like has previously been discussed, is a process. It's not a one-time thing. I review it when I do my rounds on a regular basis. I make sure that we have opportunities to talk to nursing staff when they do their quarterly reviews with patients and families, and anytime there's a change in status, we really want to review our goals of care and our goals to make sure that they reflect what the patient really wants. So it has to be something that's part of the culture, and I think it shouldn't be something that you opt into. I really think it needs to be something that you can only opt out of. It has to be part of what you normally do.
Can I add a little bit, Richard Cohen here? One of the things we've started to do in our community is to link our hospitals with our long-term care facilities, to really collaborate and start to work with them as partners so that our long-term care facilities aren't acting as independent but are acting in a coordinated way. So if we have a patient who's in our community who comes to long-term care and then comes into the hospital, and they don't have an advanced care plan, and they don't have any work in this area, then our care coordination team is going to start to work that process. The reverse is also true, that if a physician in our hospital feels that a patient is going to need to go to long-term care, one of the initial things that we've been able to accomplish is that physician will ask the care coordination team to evaluate whether there is an advanced care plan in place, if not to initiate the discussion, and then to work with the long-term care facilities to support the ongoing piece that Julie's talking about, where there's this continual discussion or at least evaluation of the process. So creating that, which goes back sort of those circles I was talking about in my presentation, where we're now trying to create collaborative relationships between the hospital and the long-term care and the other facilities in our region.
This is Bud Hammonds. I just want to support what Dr. Cohen just said, and this is an example of how a standardized approach to advanced care planning built into the routine of care across settings of care can be extremely powerful. And then I would like to add that we have to recognize that as good advanced care planning systems and processes get put in place, and we come to better understand and communicate a patient's preferences and plans for future care, we have to have palliative services in the outpatient setting and in the nursing home to make sure that we can actually honor those plans. As people get very sick, many of them come to the conclusion that going back to the hospital, and particularly going back to an ICU, is not something that they either want or will really benefit them. But when they have symptoms and they have other kind of crises, the better we can manage those in the outpatient setting, in the nursing home, in home hospice, the more we'll be able to both honor what the patient wants and take care of them in the way that they find acceptable and better utilize our healthcare resources. Thanks.
Thanks, each of you. Does anyone else have any other questions? If people are thinking of questions, I don't know, Bud, if there was any kind of, I know we kind of cut you short if you had any messages.
I apologize. I didn't have my chat panel up here, so I had the survey still on my screen, so I didn't get your messages, and I apologize for that. I just would say that what the data suggests is that good advanced care planning and in the systematic approach, as the other speakers have also addressed and spoken to, can lead to higher satisfaction of patients, higher quality of care where we match the care that the patient wants to the care we deliver. And in fact, because the choices that people make are for more appropriate resources relative to their advancing illness, we can actually reduce the cost of particularly acute care services, which are either not wanted or perhaps don't even benefit the patient. The interesting thing, if people are worried about this, is the length of life that people live doesn't really change by any of this, and there's actually in some populations evidence that the length of life increases by a less aggressive, more palliative approach. And so this does not unnecessarily shorten people's lives. The mean age of death in La Crosse County has actually increased during our work with advanced care planning and remains very similar to other counties of Wisconsin where this advanced care planning work is not nearly as developed. So this does not affect in any significant way that I can see the length of life that people live, but dramatically increases the quality of life that they have and the quality of bereavement that their families experience.
Thanks, Scott. I think that's really true. For those of us that practice in geriatrics and long-term care, it is, oftentimes the less aggressive an intervention we have, the better quality of life our patients have, and I think it's very true. We probably have time if anyone has a last question or two out there. I know we've thrown a lot of stuff out at the audience, but anything that you'd like to ask any of our speakers, please feel free to chime in.
Well, thank you, Jane, for hosting the conference call today, being the facilitator. It was outstanding discussion from Julie, Richard, and Bud. You've given us a wealth of information to think about how we proceed with this final year of our contract, but more importantly, how we begin to address the needs of our communities and work going forward.